Okay, great. Next, we have Gloria Salazar, who is the chair of interventional radiology at University of North Carolina and one of my favorite people ever, who will be talking to us about PE and PERT programs, and yet another mention of AI today, which seems to be a theme of a lot of newer meetings.
It is definitely a theme, and thank you so much for the Ramaiah family and Patty to invite me. This is a promise that I made, and I actually made it happen. So I'm very happy to be here. I agree completely with Brooke Spencer. This is high-quality discussions, and I'm learning a lot. And not only that, I'm hanging out with my friends and making new friends. And these are my disclosures. And of course, I think the organizers are very carefully doing this program, and they were very kind with me because we started the lunch with an AI overview that was fantastic. And then Dr. Nasir already talked about the PE and what are the techniques. So I figured I would tell you the story of my life. And so back in 2008, as you saw from all the publications, there's nothing like guidelines. A young Gloria Salazar, working a couple of months out of fellowship, gets called for this case, which is a pulmonary embolism. I don't even know if it was an intermediate high or whatever it was. And so I'm like, okay, so they want me to put a catheter there, rotate it, and then take it out and see what happens. So that was what happened back then. Like, we didn't have any guidelines, and of course, we were working under the Vascular Center umbrella, which I was very grateful for, and we worked together collaborative with the vascular surgeons and the cardiologists. And so I believe that I was witness of the first PERT team creation back then at the Mass General Hospital, and this is courtesy of my colleague at the time, a pulmonologist who's also part of the PERT team back then, Johanna Rodriguez-Lopez. And this was literally what we had for the PERT team. A couple of people agreeing that they were going to get together, so I'm hoping this is hopeful and this is the case for your institution, and just agreeing in a couple of guidelines. Large pulmonary embolus, so call the PERT team, and then of course there were a couple of parameters that was already discussed here, and this was the phone number, and I swear to you, like all of us carried a pager. And I remember vividly doing a postpartum hemorrhage in a hybrid OR, and the team activation for the PERT team pager going off, and then 20 people together in a phone call. There was no Zoom back then. It was all phone calls. So this is 2012. And so this is the beginning of the data that we looked into, and the reason and the whole rationale for getting together is to make sure that we're doing the right thing by the patient, that we were offering the right treatment, because we have so much expertise within our hospital, and we didn't want it to offer and not to have the options available. So as you can see in the PERT team, an initial evaluation of this data, and again, this is from Dr. Rodriguez-Lopez, most patients were treated with anticoagulation alone, and 9% only with catheter-directed thrombolysis. Now, mind you, we didn't have enough of the treatment options that we have, or the devices that we had currently available now. And so most patients were treated with lysis, and this is a nice case that we did with the Grolman catheter, getting into the pulmonary arteries and then just leaving an echo catheter in. So why would we do a PERT team? So there's many reasons, and this is another publication that you should read or you should encourage your colleagues to read. Basically, is to standardize protocols, improve the stratification, the risk stratification of the patient, make sure you're giving the right therapy for that patient with the right tools, and leveraging perspective of different specialties. I can tell you, through all my career, there's no loss in working multidisciplinary. And I have benefited tremendously in my career for that. And this is particularly true with a disease process as pulmonary embolism, which is such a high mortality, and you need to act fast, and you need to have good discussion on top of it. So, and then also you create better pathways for the patients, and you encourage the use of minimal invasive therapies. So fast forward a couple of years, the PERT concept is well established. There is a PERT consortium, as was already mentioned. Here's what it evolved to. If you have a PE, then you have a pager or telephone, you talk to a bunch of people, a bunch of specialists, there's a leader, and either you choose intervention or not, and within the intervention there's a whole range of different things that are taken into consideration based on the patient history. And here's a nice PERT activation sort of algorithm. Now, that is great and all great and good in large academic centers, but what about the community? And this is a nice publication showing what does the PERT team, how do they perform in community-based hospitals. This is like 136 activations. Most of the cases were done with ultrasound, thrombolytic, low-dose fibrinolysis with the echoes. And the outcomes, again, PA pressures, length of stay, and complications. And what they did is that the greatest differences in length of stay or baseline PA systolic pressure as compared to the ultimate study. Of course, this is a historical comparison, not a randomized trial. And then shorter length of stay as compared to the publications previously. And the good news is that every specialty performed similarly. There were no difference in the outcomes between the three specialties. So here are the last thing that I want to show is the meta-analysis that also supports what was already presented. There's no mortality improvement, but there is less length of stay days, and essentially more use of the interventional techniques. So how does AI can help us with that? And this is really, I'm talking clinical AI, screening, and then getting everybody together. So there are many points that AI can help us, not only in the detection diagnostically, but also to facilitate the PERT activation team by having all the teams and expediting workflow, really expediting the time to action and patient triage. So this is for some of you who are in social media, you have to pick only one. And unfortunately or fortunately for AI, there's so many different softwares. So I'm only going to talk about two because currently at the moment in my institution, we're trying to figure out which one we choose. And I'm going to focus on the ADOC and the VisAI. And again, I have no conflict of interest with any of those companies. But these are the two that we're considering if you're considering doing a PERT team, because they do have already an algorithm created for PE and also for other vascular diseases. And you should consider these two as first, I think, because they are doing this for a long time. So the ADOC essentially is the same thing in your phone. You just using the surrogates about diagnosing PE. You actually triage the patient, and then you have everybody on the same team. And on the phone, you can decide about the treatment. VisAI is also similar. All of those softwares have automated LV and RV-RLV ratio embedded and other hemodynamic parameters. So it facilitates the discussion. You don't need to go over the charts, et cetera. And it also interfaces with your system, medical record system. Now, the challenge is that not all the medical record systems are easily interfacing with those software. So this is something you need to consider for your hospital, depending on what it is. We're still figuring out which one is better for our hospital, and that it depends on the institution. So what are the advantages of AI? It's basically increased volume of PERT, and they give you like an estimate of how many cases you can actually diagnose with this algorithm. Increase efficiency for the diagnosis and increase care coordination when it comes to PERT teams in terms of time to treat. Now, there is a lot of papers showing or abstracts in presentations showing the emerging evidence for the use of AI in detection and the role for PE activation, so decreased length of stay for intracranial hemorrhage and PE, for example. In this one, they're mostly radiology studies, radiology diagnosis improved by AI softwares, and also missing findings, which is also another problem that we have in radiology, not so much in the interventional areas, but these are all papers that are showing the increased evidence for AI. So in summary, the PERT teams can be implemented with good patient outcomes. We still have the jury still out for the mortality risk, as was mentioned, but I do think that we do have to get together and get data for this, and AI can help us bridge some of the workflow issues that can be entailing or can be challenging you to actually have a PERT team in your hospital. Now, obviously, AI softwares come with a cost, so you just need to get, I think, a multidisciplinary team agreeing and kind of figuring out how do you actually sponsor and fund this in your own hospital. With that, thank you very much for your time.